Hello everyone, this is Dr. Madhusudan Rao and the program I teach medical students. The topic of today's lesson is vertebrobasilar stroke. It is the posterior circulation stroke, okay, involving the vertebral arteries and its branches and the branches of the basilar system. Stroke, as I told you, it is the episodic loss of neuronal function, sudden episode of neurological dysfunction, which lasts for more than 24 hours. Stroke is seen as the end-stage disease of chronic multiple uncontrolled comorbidities, yes, like hypertension, diabetes, okay, which run uncontrolled for a long time, resulting in the end-stage disease manifesting as stroke. Yes. As I told you, acute stroke is defined as the sudden episode of neurological dysfunction lasting more than 24 hours. Vertebrobasilar stroke is due to obstruction to the flow of blood in the posterior circulation, which is considered formed by the vertebrobasilar system. That is, two vertebral arteries arising from the subclavian arteries, okay, entering the vertebral canal at 6 cervical vertebra and enter the cranium through foramen magnum and unite together at the base of the pons to form the basilar artery. Basilar artery runs in the ventral surface of the pons in its center, in its midline, and ultimately divides into posterior cerebral arteries. So the branches of the vertebral arteries and the basilar artery, okay, that is intracranial part of this branch circulation is described as the posterior circulation, right? Right. This particular basilar stroke is associated with the disproportionate morbidity and mortality, okay, as they present with the non-stroke medical conditions. So thereby delaying the time-dependent interventions. Because the potentiality for complete recovery from the stroke is drastically affected if timely intervention is not taken. Okay. So when this vertebrobasilar stroke manifests as the symptoms of non-stroke medical conditions, okay, it is a suspicion or intervention is delayed, thereby causing the say morbidity and mortality, which is not actually not required. So that's why it is described as the disproportionate morbidity and mortality. Right. The risk factor for the vertebrobasilar stroke are not different from the other strokes. That means the risk factors are same as that of the other strokes, that is the anterior circulation strokes. That is hypertension, diabetes, hyperlipidemia, smoking, sedentary lifestyle, atrial fibrillation, hypercoagulable state, and illicit drug intake. These are the common risk factors for any stroke, as a matter of fact. Well, posterior circulation stroke, that is, vertebrobasilar stroke is a form of the posterior circulation stroke, accounts for 20% of the total stroke events. So we are going to touch on the lateral medullary syndrome, the most common presentation of the vertebrobasilar stroke. Well, lateral medullary syndrome is due to involvement of the lateral medullary structures, that is dorsolateral medullary structures, which are supplied by the posterior inferior cerebral artery and branches of the vertebral artery. Okay. This is the most common posterior circulation stroke. Right? It is also described as the Wallenberg syndrome, as it was first identified by Mr. Adolf Wallenberg. Okay, and this syndrome is named after him as Wallenberg syndrome. It is also called as the posterior inferior cerebral artery syndrome. Okay, well, the structures affected are inferior cerebellar peduncle, nuclei of the glossopharyngeal vagus, and the vestibular nucleus, solitary nucleus, nucleus ambiguous, and the nuclei of the spinal trigeminal, okay, then spinothalamic tract, and descending fibers of sympathetic fibers. These are the structures that are located in the dorsolateral part of the medulla, and these structures are involved in the infarct. Coming to the etiology. Etiology is due to obstruction to the large vessels. It could be large vessel disease or small vessel disease or due to cardiac embolization. Large vessel disease affects the vertebral arteries and its branches with atherosclerosis. Okay, atherosclerosis plaque results in the obstruction to the blood flow in the vertebral arteries. And sometimes there's break in the plaque of the atherosclerotic plaque, resulting in the embolic manifestations, causing lacunar infarcts. Cardiac emboli are the result of atrial fibrillation due to prosthetic valves and cardiomyopathy. The cardiac embolization is the most common cause of posterior inferior cerebellar artery infarcts. Small vessel infarct disease results in the lacunar infarcts. Vertebral artery dissection, vertebrobasilar dolichoectasia is the most common in young people, resulting in vertebrobasilar stroke. Hypertension is the common risk factor, resulting in hemorrhagic stroke. Hypoplastic vertebral artery syndrome and other causes of the lateral medullary syndrome include lactic acidosis and migraine. Coming to the epidemiology. Posterior cerebral circular stroke constitutes 20% of the total ischemic strokes, which I told you earlier. Vertebral artery disease is more commonly associated with lateral medullary infarcts compared to posterior inferior cerebral artery lesions. But one specific cause of the posterior inferior cerebral artery obstruction is commonly associated with the cardiogenic emboli. Okay, yes, as I told you earlier, cardiogenic emboli are the common cause of obstruction in posterior inferior cerebral artery. Well, the other interesting point is, well, in patients with lateral medullary syndrome, nearly 90% of the patients, they present with swallowing difficulty. Okay, well, when you encounter an elderly person with swallowing difficulty, with associated risk factor for the stroke, you have got to suspect lateral medullary syndrome. Okay, coming to the pathophysiology of various manifestations. Okay, the most common manifestation of lateral medullary syndrome is dysphagia. Okay, dysphagia is due to there's a lack of coordination of action of the upper esophageal sphincter and the lower esophageal sphincter. This is because of the lesion in the swallowing center. Swallowing center is constituted by the nucleus solitarius, nucleus ambiguous, and pontine reticular formation. Okay, these structures are involved in the infarct of the lateral medullary syndrome, thereby causing prolonged dysphagia. Well, in the lateral medullary syndrome, 50% of the cases, there is a large vessel disease associated with, obstructive stroke secondary to atherosclerosis. 15% of the cases are associated with arterial dissection, and 5% account for cardiac embolization. Okay. And the next common presentation is hiccups. Hiccups are due to the lesion in nucleus ambiguous and surrounding area. So when this part is involved in the infarct, the patient suffers from uncontrollable hiccups. Then other important finding in the lateral medullary syndrome is hyponatremia. This is because of the SIADH, okay, syndrome of inappropriate antidiuretic hormone. Antidiuretic hormone responds to hypoosmolarity of the body fluid. Okay, when the osmolarity of the plasma is lowered, okay, the signals from the carotid sinus, they pass to the posterior pituitary gland carried by the vagus. Okay. Then thereby inhibiting the production of ADH. That results in the loss of water and getting the osmolarity back to normal. Whereas in the lesions involving the vagus, nucleus arterius, and the fibers of the say nucleus ambiguous, etc. The signal transmission, inhibited signal transmission from the carotid sinus to the posterior pituitary is blocked. So, because of the disinhibition of the secretion of antidiuretic hormone, there is excessive production of or inappropriate production of antidiuretic hormone in the presence of hypoosmolality, thereby resulting in hyponatremia, that is dilutional hyponatremia in the patients with lateral medullary syndrome. This point has to be considered in the management of patients with lateral medullary syndrome, because hyponatremia as such is dangerous, which results further in the cellular edema, thereby causing nerve cell injury. Okay. Then other symptomatology include nausea, vertigo, diplopia, severe gait ataxia. This is due to the infarct involving the vestibular nuclei and the vestibulocerebellar connections. Okay. Then there is the involvement of the lateral spinothalamic tract, which manifests as the impaired contralateral pain and temperature sense. Okay. And there is the ipsilateral loss of pain and temperature on the face. It is secondary to the involvement of the spinal root of trigeminal nerve. Okay. Ipsilateral nystagmus, vertigo, nausea, and vomiting are the manifestations of vestibulocochlear nerve injury. Nucleus ambiguous infarct results in dysphagia, dysarthria, and dysphonia. Ipsilateral harness syndrome is caused by the injury to descending sympathetic fibers. There is injury to the glossopharyngeal nerve, injury to the vagus nerve. Okay, that manifests as the absent gag reflex, and ipsilateral cough reflex test is absent. Okay, these are the various manifestations of lateral medullary syndrome, and the underlying lesion and the mechanism of these manifestations are described in this pathophysiology of clinical features of lateral medullary syndrome. They are related to the structures involved in the infarct. Okay. Then coming to the brief touch on the clinical presentation. The common symptoms include vertigo, nystagmus, vomiting, ataxia, diplopia. The most characteristic feature of the lateral medullary syndrome is ipsilateral pain and temperature loss on the face, with contralateral loss of temperature and pain involving the upper extremities and the trunk. Okay. In the face, ipsilateral sensory loss of temperature and pain, whereas on the body, it is the contralateral half of the body that is affected with the loss of temperature sense and pain. This is because of the involvement of the spinal root of the trigeminal nerve and the lateral spinothalamic tract, respectively. Then, lateral medullary syndrome is sudden in onset. Okay, in 75% of the cases, and in 25% of the cases, it is more gradual in onset. Okay. Sensory manifestations are the most common presentation. Sensory manifestations, as I told you, there is the sense of temperature and pain is lost on the ipsilateral half of the face. Okay, with the loss of temperature and the pain on the contralateral part, half of the body. Right. Then other sensory modalities that presents with lateral medullary syndrome include vertigo, okay, nausea, etc. Well, other less common manifestations of gradual onset include weakness of facial movements, right? And visual manifestations and dysarthria. Well, symptoms of gradual onset include headache, vertigo, dizziness, and gait ataxia. Okay. Well, other symptoms like dysphagia, hoarseness, and hiccup occur later. These are the set of clinical manifestations, and it is very important to understand that these clinical manifestations are correlated with the lateral medullary syndrome, and that's the reason why pathophysiology of the various structures involved is described to understand the clinical manifestations. Okay. Well, because most of the symptoms presented, they resemble non-stroke medical conditions, thereby delaying the neurological intervention. So time is lost, thereby resulting in the devastating outcome with regard to the morbidity and mortality related to lateral medullary syndrome. This is all the way important for the students to remember these symptomology, and in the presence of risk factors, correlate with the structures involved, okay, thereby make an intelligent guess and rapidly proceed with the management of stroke, that is posterior circulation stroke, resulting in lateral medullary syndrome, thereby reducing the morbidity and mortality in these cases. That's the reason why detailed history is paramount importance, followed by complete clinical examination. Okay, complete clinical examination includes examination of the cranial nerves, especially the gag reflex for the glossopharyngeal. Then look for that is spasm of the masseters presented as trismus. Okay, these muscles are affected because of the involvement of the trigeminal nerve as a lesion involving the motor supply to the facial muscles, that is muscles of mastication, thereby resulting in trismus. So complete clinical examination is very important in order to understand this is lateral medullary syndrome. Cardiac evaluation to eliminate presence of atrial fibrillation, okay, other valvular diseases, and also do the echocardiography to rule out the presence of atrial thrombi, etc. Routine blood investigations, and especially the serum electrolytes to rule out presence of hyponatremia is very important in the management of these patients with lateral medullary syndrome. Imaging studies, CT to rule out hemorrhagic stroke, and MRI brain to identify the extent of infarct, okay, which will help assist in the management. Then proceed with the treatment rapidly. So keep the patient under intensive care and record all the vital data and stabilize the hemodynamic status, taking the airway care, breathing, and circulation, and proceed with the thrombolytic treatment in ischemic stroke. And sometimes mechanical thrombectomy can be carried out when there is obstruction in the large vessel disease. Secondary prevention of stroke, like providing adequate treatment for the risk factors like diabetes mellitus and chronic hypertension. And treatment also includes dysphagia management and speech therapy. These are the important points related to the management of vertebrobasilar stroke presenting as lateral medullary syndrome. Thank you very much for patient listening. And dear students, please remember the features, clinical features of presentation of lateral medullary syndrome, which may mimic symptoms of non-stroke medical conditions. Okay, high degree of suspicion is very important to avoid time delay in the management of stroke, which will be devastating, leading to morbidity and mortality if the precious time is lost in the early management of the stroke. Okay, thank you very much once again. See you later in the next class. Until that time, bye-bye.